from Ahmedabad when I was coming from flight. And when due to my flight was not available at night, I am going here from Kanpur to Delhi by train and from Delhi to Ahmedabad by flight. So I am reaching to Ahmedabad, but my journey is very difficult. I have to, like, my travel time is lot in the return. So similar way, if we use the technology, then our life can make very, very easy. Yeah, this question I want to ask you, that you have two options by going from the smooth road and by going from the bumpy rough road. Which one you will choose? I think everyone will choose the smooth one. So this is the insulin pump versus the MDI. And can you imagine the life with type 1 diabetes? It's very difficult because they always are in under the pressure of parents, from the doctor, from the peers. And what is the pressure? They need to prick for every day. Every day they have to prick for 4 times, and they have to monitor the sugar 5 times a day. And if you count the monthly, then monthly the count will be around 270 times prick that you are doing with the patient. And there is always diet restriction. Parents is always there to tell your patient that do not eat this, this is not good for you, this is good for you. So they are in the very they are in frustration, because always anybody is there to instruct them, and they have to go to school and colleges, and where the inch MDI is very, very difficult. They have to give a multiple bolus to maintain their time in range. And all of these brings a frustration among them. So they are living in under the frustration because they have to pre daily, and there is so much hurdle is going on inside. And they have always fear of the hypo. Many parents is coming to me, and they are not able to sleep at night because of the fear of hypos of their child, and might be they will get seizure. So because of that fear, they are not sleeping well, and there is always hypodystrophy and the skin site issue. And for doing all of this, they require lot of motivation to do, and it's really difficult because they do have a fear of hyperglycemia. Dr. Saurabh has said yesterday that it can open the door for the diabetic retinopathy, diabetic nephropathy, and so many complications. And they always have a fear of the hypoglycemia, acute complication. So they are living in very difficult condition. And can you imagine, they are taking 14, 16 shots per day, shots per year. It's very difficult, and they are pricking 5 times a day. Now we have available technology, and where they have to prick only once in every 3 days. Isn't it better? So what are the pros of insulin pump therapy? They reduce the frequency of injection. They is very easier to give bolus if they use the manual mode. They provide the flexible insulin delivery. You can decrease or increase the rate in the manual mode, and that in the auto mode, the driver is the insulin pump. And there is a pre-program to prevent hypo and hyperglycemia, and there is a different bolus type is available to prevent the hyperglycemia after the fat on protein consumption. And this is I would like to introduce this study among the 18,000 child from the Sweden with the type 1 diabetes. As you can see, the blue line is suggestive of the MDI, and the red line is suggestive of it is a pump user, and you can see the survival rate. It is significantly lower for the people who are using the insulin pump. And we have variety of the insulin pump. So in the first image, there is a first category plus classification of the insulin pump, where damage is already occurred, but because of the airbag, you are preventing more damage. So this is the first category of pump which was available of Medtronics. Second category, before your accident is occurred, you are stopping your car. So it is a low predictive sugar. So that is a second category, 640 G pump. And this is the advanced closed loop system, where the machine is doing all the things. You just have to announce your bolus, and according to that, the machine will work. Isn't it good? And why it is a closed loop? So in our pancreas, there is a beta cell is a closed loop. What it is doing, it is sensing the how much amount of the sugar we have, and according to that particular amount of the insulin it is giving, and it is working on the algorithm based. So this is the exactly closed loop is mean to that. Means our sensor is always talking to the insulin pump and giving the information, and according to algorithm based it is working. So this is the closed loop. And how we are doing our practice in our clinical scenario, what we are doing, we are seeing the reading from 2 weeks before, how the reading is that, and according to that we are setting our bolus. But you can see how much there is a glycemic variability is there. So basal requirements always vary day to day, and we are giving the fixed bolus. Is it right? So in the insulin pump, basal insulin is automated and depends upon how sensor is sensing your blood glucose level and what is the active insulin level. And according to that, it gives them every micro bolus at the every 5 minutes. So by that, you can achieve your steady blood glucose. And how does it work? It works that if you are following your blood sugar, then it will decrease your insulin. Might be it will suspend. So as you can see in the graphs, that during the 3 to 4 a.m. the insulin secretion is stopped properly, and if it is sugar is going up, then that time it is secreting insulin. So it is closely working like a pancreas, not exactly like as a pancreas, but closely working like as a pancreas. Yes, and Dr. Neha might be give a point that you can't give here dual bolus or the square bolus, but it is algorithm based. So when you have eaten the pizza, so in the for the pizza and for the high fat and for the high protein diet, you have to set the square bolus. But here, according to algorithm based, it every 5 minutes it will calculate, and your algorithm will change according to every 5 minutes. So it is working automatically. Here you can avoid the fake carbs entering. And if I compare about the automatic hybrid closed loop pump, and in the comparison to auto mode, there in the previous pump, we have to be a driver. And here it is working on the auto mode. So there we have to set bolus for every hours. We have to set basal for every hours. And that we have to, and it is a low glycemic prediction suspension is there. Here, if hypoglycemia is there, then it prevent the it stop the secretion. If hyperglycemia is there, then it increase the secretion. Just you have to announce your bolus. Yeah. Yeah. So the from the as you can see from clinical part and from the clinician perspective and from the patient perspective, work is very low. So isn't it good? I think yes. And you can see the timing range in comparison to ACL and the previous pump. Almost with the previous pump, the timing range was only 63 percentage, and here it was 73. So by using the advanced closed loop system, your timing range will increase. And there is a auto mode in the ACL. What is the auto mode? That it is you are seeing the blue shield. This is the significant of the auto mode, and 120 is your sugar, and 5.5 is your active insulin. So it provides the most stable glucose delivery, and it will improve in your timing range without doing much work, and it reduce the hypo, and that potentially lays mental burden in the patient and the family perspective. So, and I would like to end with the stories. This is this I took from the JDRF, from the story that was Priya was a ballet dancer, and the Jack Trigger, which was a professional sailor, and Priya was telling that the life has been changed after insulin pump. She has a more freedom what to eat, what to not. So I would conclude with my talk with one story, that if you are in the middle of the sea and if you are drowning, then you are waiting for God to come. Like फिर God भी बोलेगा कि मैंने तो भेजा था, बोट भेजी थी, वुड स्टेक भेजी थी सपोर्ट के लिए, तुमने लिया नहीं. So this is the miracle in the 21st century that we have. So when patient comes to me, कि क्या कर सकते हैं क्या नहीं, this is the available technology that we can use. And in the summary, that it is a miracle in type 1 diabetes technology that if you learned it properly, then you can sit, you can just announce your bolus, you can just calibrate with the G4. You don't have to even calibrate the system, and you will get very, very smooth control, and you have a very minimal hypoglycemia with the auto mode. So if we have option to choose Audi and to the Wagoner, we will always choose a Audi. Yeah, I understand the cost is an issue always, but I think this is the miracle. Thank you very much.
Thank you very much. I think the key points which he said for ACHL has a very good improvement in the time and range, a good comfort and convenience for the patient, and also a reduced hypoglycemia rate. Thank you very much. To counter the argument, I request the speaker, Dr. Neha, to put forth her points against universal use for ACHL.
Good morning, everyone. Thank you, Dr. Manoj, for highlighting the benefits and efficacies of insulin pump. So I will start where he ended. So he told us that if we have Audi and if we have Wagoner, which one will we choose? So, okay, I agree. Now, if you have a Audi and if you have Wagoner and if you have to drive on bumpy Indian roads, which car will you take out of your home? How many will take out your Audi to drive on a road which is full of potholes, less than concrete? Raise your hands. And if you have to have an option of a wagon or a cheaper version of a luxury car, will you not prefer to take that out from driving from NCR to Kanpur rather than Audi? I can see some heads nodding in yes. So similar is the criteria. We are not arguing here whether AHCL is good or not. We are arguing whether AHCL is good for all or not. So let's explore some challenges of the automated diabetes management. So we have clearly seen the benefits of AHCL, but do we realize that all these studies include participants from well-developed countries who have access to pump, who have access to sensor, who have access to CGM without causing a burden on their pockets? Is it possible in India? No. So that's the first speed breaker for this Audi. So my talk is whether insulin pump is a yes for our population or we should stick with MDIs with intermittent CGM if there is a possibility. So let's rewind. What actually are we discussing here? So we are just talking about AHCL, which is Minimed 780G, which we were taught yesterday. So it is an upgraded version of 670, which has Bluetooth connectivity and remote software updates. And it has the ability to deliver auto correction boluses. So a higher version of a previous insulin pump will obviously be a costlier version. So just a basic model depicting how it works. So it gets data from your CGM, it gets data from the user, and then it does some calculation and then delivers the bolus. So first thing, you need to have a good user who will enter a good data regarding his carb counting. Second, you need to use a CGM. So CGM, as Dr. Manoj has said, it needs to be changed every 3 days, right? So does it not add to your cost? So what patients are doing, they are extending the CGM to 7 days or maybe 14 days just to reduce their cost. So this does change the efficiency of the CGM. So the program which was designed to get inputs from the two things, CGM and user, now these are the limitations in a country like ours. So first thing is cost. I don't think anybody sitting here will deny that this is in fact a costlier therapy and not everyone can afford it. Second, since it is all technology dependent, it is full of errors. So if we get some technical difficulty in our Wagoner, it is cheaper to get it corrected. But if we get a difficulty in our Audi, it is always going to be heavy on our pockets. Second, it is full of technology dependence. So once you tell the patient that the pump will work for you, the patient stops measuring his own blood glucose, stops using his own brains. He thinks that the pump is going to do everything for me. So first thing first, this education has to be imparted to the patient frequently and in every visit, at least in the initial 1 to 2 years. Now, third, SMBG frequency goes down. Now, because the patient thinks that everything is being done by the pump, he stops measuring his own SMBG. So you will find some patients who haven't measured their own blood glucose for last 6 months because they are assuming that the pump is doing everything for you. But you need to cross-check the efficacy of the pump with SMBG too. Third, not every patient is digitally equipped to recognize the faults, the technical errors while using the pump. Last, there is some query regarding data privacy while we are using the pump because we are entering our own data in there. So apart from the cost, I will talk about the technical glitches that come while using the pump. First, the sensor. Is it measuring the capillary glucose? No, it is measuring your interstitial fluid glucose, which is a delay or a lag is there while it measures the interstitial fluid. So yesterday, Dr. Manoj pointed out a study from Italy which showed effectiveness or usefulness of pump during the sick days. So during my subsequent slides, I will show you a case report in which because of dehydration, CGM was measuring lower blood glucose and thereby delivering lesser insulin dose, and the patient finally landed in diabetic ketoacidosis. So the patient needs to be aware that in conditions of dehydration, your interstitial fluid glucose is falsely low. So CGM will detect falsely low sugar and in response will deliver less insulin. So chances of ketosis finally landing into DK are higher. So you need to have a good educated patient who is literate enough to recognize his own clinical condition and literate enough to adjust the digital machine. Now, second is sensor dropout. So what is this sensor dropout? So good for adult patients, but for children who have these sensor implanted on their bodies, so if they apply pressure, suppose if they sleep on the sensor, then there is a problem called sensor dropout. The sensor stops taking your blood sugar. So the child has to be aware about it. Then there is a lag in measurement, which I have already highlighted. Then there is a recurring cost, which I have already highlighted. So not only a one-time huge investment of lakhs of rupees in getting a pump, but a monthly recurring cost of nearly 15 to 20,000 rupees. So in a country like ours, what is the average income of a patient? Will he be able to spend 15, 20,000 per month? No. Then there are studies which have clearly showed that pump is not 100% safe. Like we have vaccines, but do we claim that it is 100% safe? No vaccine is 100% safe. Similarly, no pump, be it ASCL, is 100% foolproof. So we have clearly shown that there are technical difficulties such as sensor signal, lag in the measurement of the blood sugar, sensor dropouts. Now, this is the case report I was talking about, which due to a change in the body volume status, the patient landed in DKA. So this is an adult patient who was using pump with CGM. Because the patient was obese, she was prescribed GLP-1 analog, and it led to reduction in the blood volume. So there was a decrease in the measurement of interstitial fluid glucose by the sensor, thereby delivering less insulin, and thereby the patient landed in DK. So the patient needs to be aware that during sick days, you do not have to be dependent on pump, but rather check your SMBG and then deliver the boluses accordingly. So why not use an MDI with CGM? So there are multiple studies which have shown that the rate of decay while using pump and MDIs are similar. So this is a US-based study. So all the studies which Dr. Manoj have quoted are from European countries. So you can go back and check that Europeans have a lesser strict policy of passing a device. So the access to the device.
2 more minutes.
So the access to the device is more easier to get in European countries than US. So this was a US studies which showed 20.9% decay admission in users of insulin pump and 20.4% in conventional insulin analog. So is there a difference? No. So the real world experience of AHCL has pointed out. So this was a study of 41 patients which have reported 71 adverse events, which were more in insulin pump as compared to your insulin analog or MDI use. Insulin pump and cost, we all know. So what are the fallacies available in the available evidence or the literature? So participants are mostly health insured who have access to everything. They are tech savvy, not in a country like ours. And they are including participants who are just clean type 1 diabetes, do not have any concurrent illnesses. So we have type 1 adolescents who may have some eating disorder like anorexia, bulimia, celiac. So no study has been conducted in type 1 patients with coexisting illness. So before we say that AHCL is to be used for all, the study needs to include participants for all the categories, be it socioeconomic criteria, be it age of the patient, be it the illness of the patient, be it the literacy level. So the baseline characteristics of the patients need to be same while before we replicate the European studies to our demographic area. Thank you.
Yes, thank you very much. I think you put forth the points of against universal use of AHCL in a very nice way. I request the previous speaker to go and rebut the points that have been raised. The time allotted is 1 to 2 minutes.
I would like to point out with the Dr. Neha that in the celiac disease we can't use, but in the celiac disease there is always fear of the hypoglycemia. So isn't it good by using the ACL because it has main reaction of preventing hypoglycemia before it hypoglycemia occur. The algorithms suspend the insulin delivery. So isn't it good? And that I want to quote that study from the Italy that was I was talking about yesterday, that in spite of the dehydration and the sick day management, the ACL has been done very, very good. And this research has been now going to published in 2025, end of the 2025 or the 2024. We will have some more data regarding the sick day management, because there is always some some bad experience about the sick day management, but in that sick day also the ACL work is more good than the other category.
Thank you very much. And I think to sum it all up, the pros for AHCL for all, number 1 would be improved time and range. Number 2, reduction in the hypoglycemia frequency and severity. Artificial intelligence-based algorithms to have a better time and range. It is a technological surrogate of a biological pancreatic transplant. That's the key thing. And the ISPAT guidelines very beautifully shift themselves towards AHCL from the 2018 to 2022 guidelines. But whether it can be applicable for all, the very nice point that were raised was most of the data is from the developed world, and it's on a motivated subset of patients, not on a universal population. Number 3, there is very much less data on the complication rate with the use of AHCL. I think that is one thing which we would wait for. And the exclusion of very young children, I think that all is not includes even the very young children who are not currently licensed to take up this. The most important factor in our country of cost, the one-time cost and the recurring cost, and the impact of the long-term neurological outcomes with the reduced hypoglycemia frequency has not been studied or documented, and breakthrough DKA rates, which largely from the Western world seems to be saying a similar rate in both the groups. I think a lot of points are in favor of against the universal, not against AHCL, but the universal. So audience, how many of you are for universal use? Can you put your hands up? Who are against AHCL, can you put your hands up? Yeah, yes, against not against AHCL, but universal use of AHCL. Thank you very much for bringing out the beautiful flavor of this talk by night's discussions.
After interesting discussion on the first topic, we go down to the second topic today, and that is vitamin D for all. To speak in favor of I would like to invite Dr. Ayesha to give a talk, please. Dr. Ayesha.
Dr. Aisha is speaking for universal supplementation of vitamin D for all individuals.
Sir, I'll start with the first one. So good morning, everyone. Just give me a moment. Yeah. Okay, so good morning, everyone. After such a wonderful deliberation on use of insulin pumps, we move on to another controversial topic, vitamin D supplementation for all. So going by the definition of what is for all, so it is used to indicate that the thing mentioned does not affect or contradict the truth of what you are saying. So obviously for vitamin D, this holds so much true because for the next 5 or 6 minutes, I have been given this job to convince all the people present here that that universal vitamin D supplementation should be done, which I believe is not a very difficult task because I think all of you would agree that for the last decade, if there has to be an award for to a molecule for being most researched and sought after and who has intrigued the researchers worldwide, then definitely that is going to be vitamin D. For the last decade, we have seen umpteen number of like researches being done on vitamin D, and there is no condition, I would say, that remains aloof from that. Every condition under the sun, be it autoimmune, be it infective disorders, be it cancers, association of deficiency of vitamin D and response of repleting vitamin D and seeing the response is has been done for vitamin D. And I would say even for the thesis candidates, for residents working in teaching institute, vitamin D came as a respite because kuch nahi hota tha, so we used to study vitamin D association in particular condition involving all other modalities. So it has been so extensively studied that definitely we are bound to have some concerns as well with vitamin D. So when we talk about for all, so what are our concerns actually? So is the first concern is it actually supplementation? Is it actually needed? Are there any advantages of giving supplementation with any molecule? What are the benefits, evidence-based benefits of giving any particular molecule? And are there any gray areas? What can be the problems of giving supplementation with any drug? We are talking about vitamin D in this situation. And also the most important point for us physician is to sticking to the prime principle of medical ethics is the non-maleficence, doing no harm. Okay, so you have to address all these points. So talking about is a routine supplementation necessary? So there is no doubt about it from the research and the robust evidence that we have that inadequate vitamin D status in children, it may affect disease vulnerability and throughout the person's lifespan. So it's not only throughout only during the growing years or during the infancy and early childhood, but throughout a person's life, a deficient person in vitamin D may have manifestations which might involve other organs also. So talking about how frequent, how this condition is common in our country. So from CNNS data that we have, we can say that vitamin D deficiency definitely has been proven to be very fairly common in our country. And also for the adolescents, as you can see, about 25% of the adolescents living in our country are vitamin D deficient. So we have again because there have been so many studies that I cannot go into each one of these, but coming what it boils down to that is we have strong evidence that supplementation of vitamin D definitely helps in prevention of rickets, in respiratory tract infections, in tuberculosis, allergy, and atopy. So we have evidence to suggest that supplementation definitely does help in these conditions. And then we have evidence, not very robust, not very like we can be 100% sure that it definitely supplementation definitely helps in conditions like in asthma exacerbation, in incidence, reducing the incidence of type 1 diabetes, and also helps in reduction in progression of type 1 diabetes from one stage to the other, and also in certain autoimmune conditions. So what are the benefits? So definitely it cuts down the risk of nutritional rickets, which is very, very common in our country for respiratory infections. As you know, respiratory infections, they are a major contributor of under 5 mortality. So definitely if we have a therapy which has been proven to have a beneficial role, so definitely that should be used. It is cost effective, not very expensive therapy, very easily available, has to be given orally and has no problems with that. And definitely they're talking about not only under 5 mortality, but also talking about maternal and neonatal death. That is very common in our country. So definitely it has a proven benefit in reducing the risk of preeclampsia and also in preterm births and SGA births. So definitely if we have therapy, that should be used. But here comes with a caveat, because I'm speaking what the evidence says and what should be rational. So that comes with a caveat. Now we know for sure that supplementation definitely helps. If you bring up the level of vitamin D levels, that definitely helps. But still the optimum dosage, what dose should be used, what you can cause it like as an ideal biochemical value that this is beneficial, it still remains inconclusive. So definitely supplementation helps, but ideal dose is still not known for different conditions. So again, talking about nutritional evidence, as I said, we have evidence. So I'll go to the snapshot. So this picture shows a snapshot of few recent meta-analysis, which has been very nicely presented by Endocrine Society, which talks about the benefits, the proven benefits of using vitamin D supplementation for all. So as you can see, the relative risk is very low from 0.67 to 0.9. So vitamin D definitely, supplementation of vitamin D definitely helps in condition like in respiratory tract infections, both upper and lower respiratory tract infection, and also for tuberculosis infections. So keeping that in mind, we are talking about conditions where the evidence is available and those conditions which are fairly prevalent in our country. Okay. So again, talking about intrauterine, again, these are the conditions about which are major concern for our society. So intrauterine mortality, neonatal mortality, definitely we have evidence from meta-analysis from so many studies that definitely supplementation helps. And as you can see, the relative risk is 0.5 to 0.6. And now going to the other extreme, because it's so commonly available, every clinician, I'm sure in every OPD, you keep writing vitamin D supplementation for maybe indicated or maybe non-indicated conditions. So what are the adverse effects? Because our primary aim is to do no harm to the patient. So again, this is a meta-analysis which has studies, because it's so commonly available. But you have to measure whether there are any adverse effects or should it be supplemented or not. So meta-analysis, what evidence that we have, that routine supplementation, provided it's given in the adequate, the recommended dosage for a recommended duration. So there are not going to be many side effects which may harm any patient, which is something which none of us want. So this is again from recent, it's on print publication from JCEM, Endocrine Society in 2024. So again, they have done evidence and meta-analysis, and they have given a very clear and nice recommendation on whom should be supplemented. So what the evidence says that empirical vitamin D supplementation definitely should be done in children between 1 to 18 years of age. So this is being pediatricians, this is the age group to which we are catering. So definitely for our patients, routine supplementation should be done because it has been proven to have a role in preventing nutritional rickets, which is fairly prevalent. So definitely empirical supplementation should be done, and also for respiratory tract illness. Another situation and condition where empirical supplementation is advocated is pregnancy. So definitely because it has a proven role in preventing maternal as well as infant mortality rate, in decreasing the risk of preeclampsia in SGA babies, preterm babies. And so this is what JCEM guidelines says. So to summarize, so should we give routine supplementation to all? So definitely yes, especially for the population, the pediatric population that we are catering to. Specific subgroups, as I said, pregnancy and in childhood, definitely routine supplementation should be done. Long-term demonstrable clinical benefits are there, no doubts about it. And it is cost effective. You don't need any injections or any equipment like machine. You don't need lakhs and thousands and crores of rupees. So this is very easily available. So definitely that should be used, but I would say definitely used within the given dosage frame and for the time duration. So overzealous use is never advocable, and so that we all stick to the policy of non-maleficence. So this is all that I have to say. Thank you.
Thank you very much, ma'am. I think the key points with this debater has proposed is number one, it is not difficult. Number two, the stress of the benefit, which is seen even in the pleiotropic role of vitamin D in terms of the respiratory tract infections, which the Endocrine Society has endorsed, and no harm of supplementations. I think these are the three key points which this debater has very beautifully proposed. I request her opponent to come over. I request Dr. Sugandha to come and propose her points against the universal vitamin D supplementation.
Good morning, everybody. So today I'll be speaking against the topic vitamin D for all. So let's begin. So vitamin D is a fairly common name in all endocrine OPDs. We are using it right and left, but not just the endocrine OPDs. I think many doctors in their routine OPD practices are advising testing for vitamin D and also routinely supplementing their patients with vitamin D. But do you know that it's been almost more than 100 years that vitamin D was discovered in 1920 as a means to cure rickets? And within a decade, fortification of foods with vitamin D were underway, and rickets became rare in the US. And since then, it was just the beginning of research into vitamin D. Advances in knowledge with vitamin D research led to its metabolism, mechanism of action, identification of its non-canonical metabolites, genetic polymorphism, its clinical role in skeletal and extraskeletal conditions. But to review, my points against vitamin D for all will be based on these four questions. Is vitamin D supplementation really needed for all? Is there a high-risk group that requires supplementation and monitoring? And does vitamin D testing pose a significant economic burden? And fourthly, does vitamin D really have a role in extraskeletal conditions? As Dr. Aisha has quoted, I'll be also taking excerpts from the very recent JCM clinical practice guidelines that came out in June 2024. So what was done that a multidisciplinary panel of clinical experts was formed, and they did a systematic review of of placebo-controlled randomized controlled trials and in the general population. And this led to the following results, that they used empiric supplementation as a term. So they defined empiric supplementation as any intake of vitamin D that exceeds the dietary reference intake and is implemented without testing of 25 for 20 vitamin D levels. So basically, when we are giving a high dose to any non high risk group without getting tested, it can be considered as empiric supplementation. So, what are the ways in which we can do empiric supplementation? By means of taking fortified foods, by advising prenatal vitamins that contain vitamin D, or by advising vitamin D supplementation in forms of pills and drops. But in this clinical trial, the vitamin D doses ranged between 600 to 5,000 IU given as daily or weekly doses. So because the range was very wide, it was a varied range, they could not come to define the dose as to what dose is empiric supplementation, and that figure remains unclear. So just to give you a fair idea about what is the DRI in the general population, this was laid down by the Institute of Medicine in their 2011 report, and the doses for calcium varied. But if you see on the extreme right, the RDA allowance for vitamin D from ages 1 to 70 years is 600 IU only. And beyond 71 years of age, this has increased to 800 IU. But even in the pregnant and lactating females, the recommended dietary allowance is only 600 IU. And in infants up to 12 months of age, it is 400 IU. So this is an overlap of what Dr. Aisha has put forth. So empiric supplementation is required by within ages 1 to 18, more than 75 years, definitely in pregnancy, and in all those high-risk individuals who are pre-diabetic. But there is a wide age group between 19 years to 74 years where you do not need empiric supplementation with vitamin D. So coming on to screening for vitamin D. So vitamin D levels in the general population it depends on multiple factors like geographic location, the seasonal changes, cultural factors, skin pigmentation, BMI, level of physical exercise, and food fortification. So because of this varied multifactorial dependency, the screening in general population does not prove to be cost effective. So is there a high risk group? This table highlights those high risk group individuals where you can find vitamin D to be fairly common, like older people, people who are disabled and institutionalized, people working for indoor for long hours, like factory workers, workers, or night shift workers, people with dark skin, people with low levels of physical activity, people who are having chronic diseases like diabetes, chronic kidney disease, liver disorders, and malabsorption, morbid obesity, patients after bariatric surgery, patients who are on medicines that increase vitamin D catabolism, and definitely babies of vitamin D deficient mothers. But in the end, it is finally the provider's judgment to identify these high-risk individuals, get a clinical correlation, and then maybe advise for vitamin D testing. This approach seems to be more rational. So, are we testing too much and treating too much? Since it is known that 3% of mammalian genome is under some control of vitamin D, and most cells express vitamin D receptors. Rampant research into vitamin D and its metabolites saw a surge in testing for vitamin D levels, and also increase in the number of individuals receiving vitamin D treatment. So this study I would like to put forth. This study was done to uh, study the indications that were done to test for vitamin D. So in this table, as you see, that the indications in the first group, appropriate reasons for indication of testing of vitamin D were found to be in 22% of subjects, while the cause was uncertain in 7%, and the largest group was inappropriate testing for vitamin D in close to 70% of subjects in the study. So in summary, the number of 25-hydroxylase vitamin D tests performed are increasing rapidly over the past few years, with resulting increases in prescription of high-dose supplements. Many of these tests do not appear to be justified clinically, resulting in unnecessary costs to both the healthcare system and the patients. Now coming to extraskeletal outcomes, numerous studies, if you look into, they have studied the association of vitamin D levels with some extraskeletal manifestations. And here they have used higher dose of vitamin D in testing. But the benefit risk ratio of this increase in vitamin D supplementation is not clear. Here I would like to put forth some studies. They were some recent studies that were done in a large group of population. So the study from US is known as VITAL. It includes, as you can see, the number of subjects in the study were more than 25,000. But if you see that mostly these were done in the Caucasian population, and the baseline 25-hydroxylase in all of these groups is fairly within the replete ranges. And so these studies, they were using different doses to see for the effects of vitamin D. And in VITAL, they were using 2000 IU per day of vitamin D along with omega-3 fatty acids. And here they wanted to study the primary outcome with respect to incidence of invasive cancers. So they found that there was no benefit, or there was no decrease in the overall incidence with respect to invasive cancers, and null relation with respect to cardiovascular events with supplementation of this dose. Even in D health, they were giving 60,000 IU per month to the subjects, and there was no correlation, a positive correlation with respect to overall mortality, falls, and major cardiovascular events. And even VIDA and FIND study, they also put forth similar results where there was no positive outcome with respect to major cardiovascular events. But the subgroup analysis in the vital study.
Sugandha, you have a minute.
Yes. There was some improvement with overall mortality in cases of cancer, but the overall incidence of cancer did not seem to be low. So, but as Dr. Aisha has also mentioned, that there is definite role in children with recurrent respiratory tract infections and in patients with autoimmune disease. So, the possibility here could be because all these individuals were vitamin D replete, and that is why probably there was the end result was not seen, and whatever beneficial results we have seen with other studies were probably conducted in individuals who were vitamin D deficient. So large supplementation trials recruiting vitamin D replete adults have demonstrated no effects. To summarize, the long known skeletal benefits of vitamin D remain valid, but the most reported extraskeletal benefits of it were not confirmed by these large RCTs. So, thus to conclude my statement here, I would say that when it comes to vitamin D, it is advisable to give it to those who need it. Thank you.
Thank you very much, Dr. Sugandha. You very nicely put out your points again. I think two key points was she very beautifully dissected out the new 2024 guidelines. It is not how the universal recommendation is kind of dissected to meet not only supplementation but also in the fortification, etc. And second thing, you very beautifully brought out that the pleiotropic role of vitamin D is more like a relationship between a boyfriend and a girlfriend. It is not a strong relationship. So I think thank you very much. And now I request the Dr. Aisha to put her points of rebuttal against.
Yeah, I think we both agree on one point that it should be given in some specific subgroups. So like what the study she talked about where there were no extraskeletal manifestation, most of them were adults. So we are dealing with children here. So as far as childhood is concerned, so they recommend that because there is definitely role of supplementing vitamin D in children because it helps in prevention of nutrition rickets. Another thing, the routine supplementation that you talked about was IOM guidelines 2011, and what we are following is IAP guidelines 2021 that recommends the dosage recommended a bit higher for children. So that is the point that I would say.
Thank you very much. So I think to sum it all up, I think the universal supplementation of vitamin D for infants cannot be questioned. I think less than 1 year, I think all of us will definitely agree.
Yeah.
And the supplementation in high risk states can also not be debated. That is also something which we all would agree upon. In between the age of 1 to 18 years, without any risk factors, I think the supplementation would probably have to be in the form of health advice on taking up the IAP guidelines, 2021 guidelines on sunlight exposure of vitamin D, of exposure to prevent vitamin D deficiency rather than nutritional supplementation of vitamin D per se.
On that, supplementation does not always mean you give tablets. So supplementation could be in the form of food fortification and even sunlight exposure. So that is the point that is very important. Supplementation does not always mean you have to give something medical.
I think this is one debate where both the proponents are agreeing on the conclusion of the chairpersons, and I'm incidentally very want to bring out one point that Dr. Aisha is one person who has been a part of the 2021 guidelines, which speaks against vitamin D supplementations, but she has very beautifully argued.
That's why I'm sticking in between.
I think that is the flavor. I request all the audience to please read the 2013 Global Consensus, 2017 IAP Guidelines, 21 IAP Guidelines, and 24 Endocrine Society Guidelines. You will see the evolution of guidelines of how it has moved from supplementation to prevention of toxicity. Thank you very much.
For the next debate, we have interesting topic of growth hormone in patients with idiopathic short stature, a very gray area, and we would like to see how it goes. To speak in favor of growth hormone for ISS, I have Dr. Vijay, and to speak against this is Dr. Vibha. So I request Dr. Vijay to give his talk in favor of growth hormone for ISS.
So Dr. Vijay is well known in this region. He needs no introduction. He is currently the head of department of pediatrics at Meerut Medical College, LLRM Medical College, and he's also working a lot in terms of different aspects of pediatric endocrinology in that region. Over to you, Dr. Vijay.
Thank you, sir, and good morning to all of you. So first disclaimer is that I don't have any financial interest for any pharma company. So this is very clear. I'll start my talk that there is a word if, perhaps, and in Hindi, kash. You can see the agony of the family that there is a problem. Problem is short stature. There is a drug which can be offered, or rather at that time, probably that can be offered with varied results. So let us see that whether growth hormone for what is ISS, that is idiopathic short stature. What it mean? मतलब कि हमें नहीं पता है तो इसलिए क्या इसका ट्रीटमेंट नहीं करना है? No. So ISS is currently defined as short stature with height minus 2.25 standard deviation, absence of abnormal physical features and normal general screening investigation, normal body proportion. The third, that is absence of and normal general screening investigation, but it is a rider whether how much I have investigated in the interest of the problem. Normal body proportion, absence of major dysmorphic features. So this is not a diagnosis, but problem or complaint as a short stature or short height. So what I'm going to discuss that why I'm here, that FDA and EMA, that is European Society and this FDA, got authorization for growth hormone prescription in ISS. So how it goes? Okay. Okay, sorry. Yes. So we have discussed that this is not a diagnosis and approach to policy analysis. So how we are going to approach a general problem, that what is the problem represented to be and what is FDA's argument that growth hormone has been approved for some non-growth hormone deficiency pediatric indication to treat growth impairment. Here is not diagnosis and not the underlying condition, and that human growth hormone has similar safety and efficacy profile for these conditions and idiopathic short stature. So human growth hormone should be approved for the indication of ISS. Why not ISS? If there are plenty of non-growth hormone deficient conditions are there. Yes, so short stature is disadvantage, and that correct the current inequity in the treatment if availability is there. So two main assumptions were there, that short stature is a potential disadvantage regardless of its medical explanation. Even if you don't know the exact diagnosis, human growth hormone promotes equity by preventing discrimination based. Yes. So if untreated, children with ISS commonly achieve adult heights that fall below adult heights predicted for them during childhood. So again, the analogy between non-growth hormone deficient short stature. So it should be provided. So growth hormone provides fair opportunity to use in children with ISS. Yes. So similar height gain as Turner syndrome. This is again a growth hormone deficient condition. It brings the mean height of children into the normal range during the treatment. Third, that is treated patient reached near normal range in adulthood, while those in the placebo group didn't. So in this view, if short stature brings disadvantages, the normalization of height is a benefit as it addresses such disadvantages. Yes. Again, the thing is that medical understanding of short stature, that is growth impairment, growth disturbance, or growth failure. At the same time, it describes short stature as a potential psychosocial disadvantages due to social discrimination and current functioning of society. So this is the way the medical model understand disability in medical terms as a functional impairment or limitation and as a problem of inherent to individuals. So definitely there is a knowledge gap for idiopathic short stature. We have measured growth hormone, we have done the provocative testing, but beyond growth hormone level, there are so many factors and receptors and other things which are going to play for the final height outcomes. You can see here in the picture. That is cytoskeletal cell growth, protein synthesis, lipolysis, so many things. Yes. So what can be the, so this study I am quoting that in 2021, that variants in the gene regulating growth hormone action with phenotypes, normal phenotypes, consistent with idiopathic short stature. So what we have labeled as a idiopathic short stature probably can be pathological if we are going to dig out more deeply. So therefore, it has been suggested that less deleterious growth hormone receptor gene defect may cause ISS associated with features of growth hormone insensitivity. But it doesn't mean that it is growth hormone resistance condition. So I'll discuss that dose escalation can be done and the children can be improved. Yes, again, the more skeptic scenario, if we are going to give growth hormone, improvement kitna hota hai? So this is not a fixed number because ISS is an umbrella term and we have to explain the parents, the patient itself, if he or she can understand, and the convincing. So if the trio are going to make the commitment, then probably we are going to give growth hormone therapy. Yes. So differences in the response to recombinant growth hormone therapy on height gain in patient with idiopathic short stature versus patient with growth hormone deficiency. And in this study, they have quoted fairly the same, but a bit higher in case of growth hormone deficiency. Yes. Again, that before labeling idiopathic short stature, we have to really find out the cause of the short stature. And now we are going to have the newcomer, that is genetics. And by this, we can have so many things. And even you can predict that if you are going to prescribe growth hormone therapy in that particular situation, how much response you are going to gain. So these were the analysis that these patients has been benefited, and the short-term use of growth hormone has potent and similar effect on increasing the height of both patients diagnosed with idiopathic short stature as well as growth hormone deficiency. So the same thing that idiopathic only after diagnostic evaluation, that is the important thing. And you can see in the next, that is multi-gene sequencing approach can determine the genetic etiology of short stature in up to 1 in 6 children with ISS. So this is a big thing that still we are under investigating the children, which we are labeling idiopathic short stature. So yes, so this is one of the most important slides. That if you have evaluated the growth failure, so their extreme growth hormone deficiency, we all know. Even growth hormone deficiency, we are fair that by giving growth hormone is going to increase. Idiopathic short stature is the gray area where we have to counsel the parents. We have to tell in detail that these are the things which are available, which can be tried. In growth hormone resistance and in case of extreme growth hormone resistance, there is no need to give growth hormone therapy, rather IGF-1 to be given.
Vijay, time is almost up.
Yes, sir. So just I am winding up. Yes. So what we are going to, so in that study, they have found the SHOX haploinsufficiency, FGF signaling effect, CNP, NPR2 pathway defect, and ACAN mutation. So there were so many things which has came out once we have investigated thoroughly, which were initially labeled as idiopathic short stature. Yes. So this is probably my concluding side that so growth hormone to be given in all patients of ISS? Absolutely not. So the challenge for a clinician who is presented with patient with short stature, who has normal growth hormone secretion, but deserves growth hormone therapy because of significant short stature, revolves around decision of whether to treat with growth hormone doses appropriate for growth hormone deficiency or use higher doses as advised for ISS. Alternatively, IGF-1 be prescribed based on evidence of growth hormone resistance. Yes. So shared decision making is the key. For non-growth hormone disorder, it behoves the clinician to inform the patient family that not treating is again an option. So it doesn't mean that this is a blanket thing, ISS, and whether we have to treat or not. No, absolutely not. So triad of patient, parent, and pediatrician are going to make a difference. So thank you so much. And the last practice, physician to identify and appropriately treat any underlying pathology, frank conversation about potential benefit and side effects, remain receptive to patient and parents' need and concern. Set realistic expectation so patient family can make well-informed decision. So thank you so much. Yes, questions are guaranteed in life, answers are not always. So this is the way that how we are going to perceive ISS. Thank you.
Thank you very much, sir. You walked a tightrope walk of
Yes.
advocating universal growth hormone for ISS by putting forth the points of idea of equity, that is promoting of equity as number one, and number two, gain in height similar to in childhood as well as in adulthood as possible arguments in favor. Now I request the opponent to put forth her points against the use of universal growth hormone in idiopathic short stage.
Thank you, sir. As Vijay sir has already set my ground, like he has to say that growth hormone is an option for all ISS, and you have already mentioned it. It is not an option for all. It is not recommended as a routine for all the children with ISS. So starting with that, even the GHR's guidelines recommend that it should not be used as a routine treatment for all the children who had height standard deviation less than 2.25 standard deviation. And if we see that in India, the children who are below minus 2.2 standard deviation is approx 60 to 80% of the children will fit into that. And if we calculate it the population wise, it is around 14 lakh 40,000.